So this is the exciting part. We've got this new cardiac CT system. It's a 1152 slice by Siemens. It's a dual source system. Now what makes this amazing? What we look for is we look for speed and we look for quality of imaging. Then this, for cardiac CT, you don't need a beta blocker. 120 beats per minute, you don't need a beta blocker, and you get such beautiful images. If you can see a standard CT, you can't even see calcium, but with this, you can see the calcium right there. This is a bypass, post-bypass, as you can see. These are just superb images, but Dr. Smriti will talk more on that. This is also a patient that came with chest pain, ECG normal, had no idea what to do. We sent him for cardiac CT, and immediately you can see the coarctation right there. The pulmonary imaging, this is something very interesting. What we realized is that instead of doing PFT on this machine, you can check lung volume. So on the CT scan itself, you can see lung volume. So if you can see here, one is perfused and one's not perfused at all. But there was another slide I had, it's not here. It'll even tell you the lung volume, FEV1 and everything. So this you can see is just a stent in the aorta at bottom near the renals. Now this is very interesting. What makes this machine very special is that in children you normally have to give sedation to do a CT, but with this you don't. This patient was just 14 days old, had a paraspinal mass and a ganglioneuroblastoma, but because of the CT we didn't have to sedate him. Immediately we could just do it and we found a compression on the spinal cord. 1 second it took. This is also another great breakthrough. Our MRI 3T machine, it comes with the AI technology called SmartSpeed. It's by Philips. Now what this does, again the same, it's about giving the best quality with the fastest as it could be for the patient. As you can see here, a normal conventional 3T, you will get it done in about 25 minutes for a knee. In this it's just 7 minutes. You can see how artificial intelligence has really rapid the pace and even better picture quality. We also have a hybrid cath lab, very good for aortic work. So the whole cath lab turns into a theatre. The C-arm moves out and you can make it into a theatre. This is a biplane cath lab mainly for neuro work, for strokes, and so on. This is, as you can see, we can do coiling for stroke patients if they come on time. CyberKnife is a new entity what we've got. It's about a year old now. What it does is it uses SBRT, which is stereotactic body radiation therapy. What it does is in the brain, if you have tumors, it pinpoints the tumor and it irradiates it in that space. But it's also good for lung cancer as well. And what makes this iconic is that it uses AI to move with the breathing. So at the same time the patient's breathing, it's able to do therapy without stopping. Another good thing is in trigeminal neuralgia, we're seeing very good results with that. But I'd love to say that any patient who has cancer under the age of 18 is not affording, please, I insist everybody here to please send them to Ruby. We will do it completely free of cost. This is a new method, it's called lutetium. It's from the nuclear medicine department. What it does is, it takes, for example, PSA, and then it uses that PSA to go around the body. If you see here, this patient had complete mets everywhere. This was in 2023, and now if you see, the patient is completely cured. Da Vinci robot, we've done over 500 procedures, mainly Euro work. We're planning on getting the new system soon as well, the XI. The PET, we do about 50 a day, not 120, sorry. We do about 50 PETs a day. And this was the first machine we got in India, which is used digital PET, so it's very fast and also superb quality. Now, this is a cyclotron. We'll be the first hospital in India to have a cyclotron and a PET scan in one premises. What is the advantage of this? So FDG is what it produces. FDG is what you need to inject into patients to see where the tumors are. So, or if it's metastatized or not. But the problem is the half-life of FDG is very poor. So by the time it comes from Bombay, we buy it from Bombay, and it comes to Pune, already half is gone. So what we've done is we eliminated that factor by putting one in the hospital itself. But it's not just that. It has non-FDG applications. So what that means is that for stuff like bone and prostate, even breast, we even have these special markers which we're working with Stanford to do more research with. So it's got a very good research base. So this is the new lab we've got, automated lab. It does 1,500 samples an hour. So what also makes this unique is what we've made it completely autonomous. Throughout the hospital, we've put pneumatic chutes. So at the ward level, you just put the sample in, immediately it will go into the system without any human intervention at all. It's completely automated. In 1 hour, you get the result. So as you can see here, this is how it is. It's directly inserted from the ward or the casualty or any area like that and sent. So this is also what we've got in endoscopy. It's a CAD-eye system by Fujifilm. And we've also got the spyglass. Now what makes this is it uses virtual AI. What's virtual AI? Virtual AI is when the doctor goes down into the gut, and if it sees any polyp that it misses or any sort of cancer, it will use AI to try and pinpoint that exact location so you don't miss it. It's very great technology and the picture quality is superb. So Rezum is a new treatment for prostate. It uses just water vapor for the treatment for hypoplasma, for prostate above 30 centimeters. Best is no erectile dysfunction, nothing. The patient can just walk home. It's an OPD procedure. And superb results. It's by Boston Scientific. So charity, we do a lot of charity. We've done about 100 crores in 4 years. Last year we've done 32 crores in charity. We're very proud of it. And this year even more. So we've done 500 free pediatric open hearts for patients below the age of 18. And please, if you have any cases, please send them. We will do it free of charge. So we also have a metro. It's great. All our staff uses it, including our CEO who's here today. So, but now what's next? I've already given you such great technology. So what's next? How do we make technology better for healthcare? So this is MRI-based Linac. So this will be coming in February. It's a 100 crore machine. What it does is it uses MRI technology with linear accelerators. As you know, linear accelerators is a blind approach. So when you're irradiating something, you use a previously done MRI to see exactly where the tumor is. With this, it's a live system MR built in, so you can actually pinpoint where it is or if it's shifting. So it's a great technology and everything will soon be MR Linac based. Now what we've done with the theatres is we've integrated. We've decided to get complete integration with the phone so patients can have live streaming anywhere in the world. You have telestration, somebody's in America, you can view the procedure. If you need an pull out an MRI while doing an operation, immediately you can get it on the system. So this is done by Karl Storz, and this will also be the first in India of its time. Now what we've done in Ruby is we want to go paperless by the end of 2028. By doing so is we've got a new system for HIS, Hospital Information System, and EMR. So when the patient's at home, you can book appointments, get tests done, visit doctors online, and then once they reach the hospital, they'll get parking easily, immediately they'll get to the room, the Mediclaim, everything will be processed, doctor can start treating the patient. GPs will get automatic updates through this system. So when they have their patient admitted, they can view automatically on their phone how the status of the patients are. And then even at home, the patient goes home, discharge is short, and patient progresses updates to the GP as well. So it's a complete integrated system, and it also integrates, as you see here, with insurance companies. So no need for a medical department. It's directly integrated, and even for any government organization. So I just wanted to share what we're doing here to try and go paperless. So as I said, paperless by 2028, and I thank you very much. Really enjoyed being here.
Dinesh Oswal, Vice President. लाइव जा रहा है।
दूसरा का नाम तीसरा का नाम क्या है? दीक्षित ना?
वाइस प्रेसिडेंट को क्या नाम बोला था?
Dinesh Oswal.
दिनेश।
Good evening, everybody. Thank you for having a huge crowd. I thank the President of Baramati and the Secretary, Mr. Pillai, for cooperating with us to have a grand occasion. Now, I would request Dr. Simon Grant to felicitate Dr. Rajendra Chopade. I would request Dr. Smriti to felicitate Dr. Chandrakant Pillai, the Secretary of Baramati.
Dr. Dinesh Oswal.
Now I could request Roxport, the CEO of Ruby Hall, to felicitate Oswal, Dr. Oswal. He's a Vice President. Thank you all. Now I would request Dr. Smriti to come here on the stage and give a speech.
Thank you, sir. Dr. Simon, sir, it was a very informative lecture with AI advanced technology of cardiology. Dr. Smriti Hindaria, a consultant cardiac surgeon with over 80 years of experience, 8 years more of experience, thousand successful surgeries, currently practicing at Ruby Hall Clinic, Pune, with previous roles at Dr. D.Y. Patil Medical College and Fortis Hospital, Mumbai. Specializes in minimally invasive cardiac surgeries, pediatric cardiac surgeries, and various valve procedures. For qualification, MCH in cardiovascular and thoracic surgery in 2015, MS in general surgery 2012, MBBS in 2009. Honors, recipient of multiple awards for excellence in cardiac surgery, including the Times Now Health Icon Award in 2022 and various academic prizes during medical training. Additional trainings completed observership in minimally invasive and robotic cardiac surgeries across several prominent hospitals in India. Publications contributed to 2 publications and presented 3 posters at national conferences. I would request Dr. Smriti Madam to please deliver the next.
Good evening, everyone. It's been a pleasure to be here amongst you all to share my experience and to just enlighten you about what we are doing at Ruby Hall and what is the scope of cardiac surgery today. So the first cardiac surgery in the world, it was performed somewhere around 1893, and first open heart surgery in India around 1962. So it's been decades, in between around almost 70 to 80 years we took to develop this field. Since then, henceforth, and we have been trying to develop the field, and over the past few years, over the past 10 to 15 years, the development has been very fast. Development includes everything, the approach to the surgery, from where we do the surgery, the indications, what all patients we accept, what all we don't, and the post-op care, pre-operative stabilization, everything is developing at a very fast pace. So one by one, in very short, I'll just give an overview of where we stand today and how we are developing this practice. Like I said, the development is in various fields. The technological advancement mainly include minimally invasive cardiac surgery. The second would be robotic cardiac surgery or robo-assisted. Mostly it's robo-assisted only. Complete robotic, total robotic cardiac surgery is being developed in India in some centers. It's being done outside India at various places like Chicago and Turkey. And advanced imaging techniques. Dr. Simon sir, he showed you the images of cardiac CT scan, cardiac MRIs, beautiful images. The new CT which we have, the one which she showed where it was a post-bypass CT scan. We know where the graft comes from. We can reconstruct 3D, the entire image. In a coronary angiography, conventional coronary angiography, we get only a 2D view. We get only a 2D picture. Of course, we get the dynamics, but it's only 2D. So this cardiac CT with 3D reconstruction and MRIs, they give very beautiful 3D images where we can make surgical decisions based on those. Enhanced recovery after surgery protocols or ERAS protocols. These protocols have been in place for quite a while now. In the initial days, like Adi Jiva surgery Vaichi, usually when I did my MCH, it's been only I think 10-12 years I finished my MCH. And during that period, we electively ventilated patients. किती stable patient असेल, straightforward bypass असेल, straightforward wall replacement, but overnight ventilate करायचं. 24 hours करायचंच आहे, किती stable patient असेल. But now it's not so. If we feel that the patient is stable, just like any other surgery like hernia or hydrocele, we extubate the patient maybe within 2 or 3 hours. We encourage early mobilization. असं काही नाही की पेशंटला झोपूनच ठेवायचं आहे, 2-3 दिवस चालू शकत नाही, हालू शकत नाही. We ensure that the patient is mobilized as soon as possible so that the morbidities which come along with delayed mobilization, they are taken care of. Like bed sores आहे, atelectasis आहे, lung issues आहेत, ते सगळ्या गोष्टी अवॉइड होतात. And patientsला पण कॉन्फिडन्स भेटतं. He is mobilizing very fast, then त्यांचं जे रेग्युलर रुटीन आहे ते पण लवकर चालू होतं. So all this is included in ERAS protocols. It also includes using different techniques during anesthesia like epidural analgesia, intercostal nerve blocks, whereby the pain relief is very good, so that the patients are very comfortable post-operatively. Initial days मध्ये industrial doses मध्ये आपण supports लावायचो, adrenaline, noradrenaline, dopamine, whatever supports were there. But now we decide the supports based on the transesophageal echocardiography, the post-operative echo of the patient, how the patient is behaving, and depending on that we decide the supports. It's not industrial now. की प्रत्येक पेशंटला हे 4 support गेलेच पाहिजे. It's not like that. We customize according to the patients. I would be focusing more on the surgical part of it. Being a cardiac surgeon, that is what my forte is. So intraoperative techniques, they have developed leaps and bounds over the past few years. The main development is from on-pump we have come to off-pump surgeries. It is said that Indian surgeons are very good. This off-pump surgery or the beating heart surgery, almost 90% of the cases which we do are beating heart. But once we go outside India, other places, people still prefer on-pump surgeries because they feel that the grafting will be more complete with on-pump. But it is not so. With the correct instruments, the correct technique, and an extensive preoperative planning, almost 90% patients असे असतात की आपण beating heart करू शकतो, off-pump करू शकतो. And on-pump surgery nowadays is reserved for those patients, CABGs, whereby the ejection fraction is very low, 20-25%. They have some valvular regurgitations like mitral regurgitation or aortic regurgitation, or the patients who have very high PA pressures preoperatively. So all these things we predict preoperatively and then we decide whether it will be on-pump or off-pump. But 90% of the times we are able to do surgeries off-pump. So what is the benefit of an off-pump surgery? In off-pump cases, the inherent disadvantages of the pump, that is the heart-lung machine, they are avoided. आपल्याला हेपॅरानाइज जास्त करायला लागत नाही, सर्जिकल टाइम कमी होतं, कॅन्युलेशन, एक्स्ट्रा सुचर लाईन्स सगळं अवॉइड होतं. But of course, there is a lot of skill involved, a lot of techniques involved, and the learning curve is great. So we have to practice continuously so that we develop this technique. The second development is conventional versus open heart surgery versus minimally invasive. Whenever a patient comes to us, एखादा पेशंट ओपीडीत आला की त्याला सर्जरीची गरज आहे, the first question patient will ask is किती मोठा चिरा होणार, किती उघडणार तुम्ही, किती पाडणार तुम्ही. मग त्यांना हे कन्सर्न नसतं की ऑपरेशन नंतर विल बी बेटर, ही विल इम्प्रूव्ह सिम्प्टोमॅटिकली, दॅट ही नीड्स दिस सर्जरी. कुठून करणार, किती मोठा करणार, किती टाके असणार, किती दिवस लागणार, ह्या सगळ्या गोष्टी त्यांच्यासाठी जास्त इम्पॉर्टंट असतात. सो बीइंग सर्जन्स वी ट्राय टू minimize the injury done to the patient. We try to reduce the incision, the length of the incision, the invasiveness of the procedure. And during the past few years, like I said, whatever 10-15 years, the main focus is on this only. A surgery which we can do through a thoracotomy, a mini thoracotomy or endoscopically, why not offer those to all the patients? So this is mainly to reduce the length of the incision, the cosmesis, the comfort of the patient and the faster healing. So patients who are suitable for this procedure, we can of course offer them the minimal invasive option. Then the next most important thing is complex procedures or redo procedures. In the initial days, complex surgeries like Bentals, aortic root replacement, ascending aortic aneurysm is there, aortic regurgitation is there, or aortic dissections, all aortic surgeries for that matter, redo procedures like second time, third time wall replacements, redo bypass procedures, all these procedures carried a very high risk. But over the past few years, we know what should be done, what should not be done. There are techniques developed whereby we don't go ahead with a straightforward sternotomy. Different sternotomy techniques are available. We can go on peripheral cannulation, femoral bypass techniques are available, making it more safe for the patient. So if these options are available, हे का matter करतं? Because we have to give these options to the patient. Patientला स्वतः माहिती नसतं की हे सगळं available आहे, की दुसऱ्यांदा, तिसऱ्यांदा, चौथ्यांदा सर्जरी होऊ शकते. But now the techniques are so developed that we can do that. Once the patient comes to us to OPD or to a family doctor or to a general physician, if the information comes from there, it's easily accepted. Direct cardiac surgeon कडून आला तर usually patientला accept होत नाही. पण त्यांचा फॅमिली डॉक्टरने किंवा जनरल फिजिशियनने ज्याच्यावर त्यांचं फेथ असतं त्यांनी सांगितलं तर ते इझिली एक्सेप्ट करतात. So this is another field that we are developing. We are doing very complex procedures with great results. The overall mortality rate, morbidity rate is reducing day by day. For a coronary artery bypass grafting or a routine wall replacement, the mortality nowadays is around 2 to 3%, and the 5-year survival is more than 90%, which is very good. The next important development is in the field of heart transplant and LVADs. But here there is a catch. We don't have many donor hearts available. जिथे जिथे transplant programs आहे, recipients भरपूर आहेत, हार्ट फेलियर क्लिनिक्स ऑनगोईंग आहेत, बट डोनर हार्टचं ऑब्व्हियसली पॉसिटी आहे. डोनर हार्ट इझिली अवेलेबल होत नाही. त्याच्यामुळे हार्ट ट्रान्सप्लांटचा नंबर अजूनही थोडं लिमिटेडच आहे. बट येस, पेशंट्स की जे खूप क्रॉनिक हार्ट फेलियरमध्ये आहे की ज्यांना दुसरी सर्जरी आपण ऑफर करू शकत नाही, त्यांच्यासाठी ट्रान्सप्लांट हे ऑप्शन अवेलेबल असतं. An LVAD or left ventricular assist device, it is a bridge to transplant or bridge to therapy, destination therapy. काही पेशंट्स असतात की ज्यांना डोनर हार्ट अवेलेबल नाही आहे, पण त्यांचं स्वतःचा हार्ट इज रिक्वायरिंग लॉट ऑफ सपोर्ट्स अँड खूप इश्यूज होत आहेत, कंटिन्युअस ॲडमिशन्स लागत आहेत, तर त्यांना आपण LVAD हे ऑफर करू शकतो. हार्ट ट्रान्सप्लांट्स अँड LVADsचं ड्रॉबॅक आहे की कॉस्ट फॅक्टर इज लॉट, म्हणजे बेसिक आपण म्हणतो अराउंड 25 lakhs to 30 lakhs पर्यंत याचा कॉस्ट मिनिमम जातात, त्याच्यापेक्षा जास्त पण होऊ शकतं जर पोस्ट ऑफ स्टे जास्त असेल तर. So not every patient it's possible to do this. Affordability issue is a major thing. Next is anesthesia consideration. I mentioned about this earlier. ERAS protocols. Anesthesia मध्ये जे mainly develop झाले those are the ERAS protocols. की patient ला better analgesia द्यायला पाहिजे, early extubation, planning the supports according to the patient. Industrial doses मध्ये just असं support देत राहायचं असं नाही आहे. Planning the IV fluid, blood transfusion, whatever factors are required as per the patient requirements, and blood conservation strategies. So, like I said, as a cardiac surgeon, we aim to improve patient comfort by reducing pain. So, pain reduce करायला दोन टेक्निक्स आहेत, ते इन्सिजन छोटा करू शकतो, नाहीतर जे एनाल्जेसिया टेक्निक्स आहेत ते इम्प्रूव्ह करू शकतो. एनाल्जेसिया टेक्निक्स दे आर द फोर्टे ऑफ एनेस्थेटिस्ट. कार्डियक एनेस्थेटिस्ट जे आहेत इंटरकॉस्टल नर्व ब्लॉक्स देतात किंवा फिमोरल ब्लॉक्स देतात, किंवा एपिड्युरल एनाल्जेसिया पण कुठे कुठे यूज होतं. अँड अडल्ट अँड पिडियाट्रिक दोन्ही पेशंट्समध्ये हे यूज होऊ शकतं. अँड रिड्युसिंग द इन्सिजन दॅट इज द जॉब ऑफ द सर्जन, दॅट इज व्हॉट वी डू. इनफॅक्ट आजकाल स्टेनोटॉमी इन्सिजन्स पण खूप मोठे नसतात आणि खूप चांगली हिलिंग होते. Minimal invasive surgery मध्ये incision is only about 3 to 4 inches instead of 6 to 8, which is required for a conventional surgery. And like I said, early mobilization back to social and economic life, both is important. Post-operatively most concern काय असतं पेशंटचं, किती बेड रेस्ट राहणार, कधी रिटर्न होणार ऍक्टिव्हिटीला, जॉब कधी चालू करू शकतो, काम कधी चालू करू शकतो. तर आवर एम इज ऑल्सो द सेम की पेशंट सोशल लाईफमध्ये आणि इकॉनॉमिक लाईफमध्ये दोन्ही ह्याच्यात कम्फर्टेबल ॲज सून ॲज पॉसिबल व्हायला पाहिजे. So one by one, I'll go through the just pics of the procedures and examples of the cases, just to provide an overview of the scope of this minimal invasive procedure. So minimal invasive most commonly used for ASD closures, os ASD, ostium primum, all kinds of ASD can be done through a right thoracotomy. And it's a very straightforward and a very simple procedure. The exposure is also very good. When we do it through a sternotomy, usually the right atrium is on the lateral side. We approach the ASD through the right atrium. जेव्हा आपण thoracotomy करतो ते इट्स बँग ऑन, म्हणजे जर आपण राईट इंटरकॉस्टल स्पेस ओपन केलं तर डायरेक्ट राईट एट्रियमच येतं. तिथून उघडलं की ASD ॲक्च्युअली बेटर दिसतं रॅदर दॅन स्टेनोटॉमी. बट ऑफकोर्स ते सर्जरी करण्यासाठी जे कॅन्युलेशन असतं, जे हार्ट लंग मशीनला कनेक्ट करायला आपल्याला बायपासवर वगैरे जायला लागतं, दॅट इज व्हेरी डिफिकल्ट. कॅन्युलेशनसाठी अप्रोच लिमिटेड असतं, इन्सिजन छोटा असतो, स्पेस छोटी असते. बऱ्याचदा मी जसं म्हटलं फिमोरल कॅन्युलेशन पण करायला लागतं. त्याचे पिक्चर्स पण आहेत, आय विल शो यू दोज पिक्चर्स. Similar for wall replacements, mitral wall replacement, aortic wall replacement, both can be done through minimal invasive techniques. Double wall replacement is not possible because the approach is entirely different for mitral wall and aortic wall. So that will be through a conventional this thing only. And CABGs. CABGs, single vessel, double vessel, triple vessel, all can be done provided the patient is in a suitable condition. There are specific indications. This particular picture, this is a thoracotomy in the left fifth intercostal space. This is a mid-cap case. Mid-cap is minimal invasive direct coronary artery bypass, whereby only the LAD is affected, just single vessel is affected, and this can be done through routine instruments. We don't require any different kind of instruments, any special instruments. Only the this rib retractor. It's a different instrument made so that it will be atraumatic for the ribs. But otherwise, what we are seeing here, this is the left ventricle directly through the left fifth intercostal space. And from here, we can do through entire CABG. Usually, we harvest the lima through the same space. There is a different kind of retractor which we place here, and they hitch करतं thoracic cavity ला, and वरती आपण lift करतो. And जे left internal mammary we can see through the sternotomy, we can see through the same incision, but from the lateral side. Here, from sternotomy, we see through the medial side. So it's very much approachable, not very difficult, but obviously technically and skillfully जरा जास्त skill लागतं आणि dexterity पण जास्त लागते. And of course, since we are doing through small incision, so backache, neck pain, त्या सगळ्या गोष्टी होतात. There is a huge learning curve for this, but it's very beneficial for the patient when done correctly. So this is the same patient. Like I said, it was a single vessel disease, long segment CTO LAD. CTO म्हणजे क्रॉनिक टोटल अक्लुजन, जे प्लास्टिकसाठी सुटेबल नव्हतं. सर्कमफ्लेक्स सिस्टम अँड राईट सिस्टम वॉज नॉर्मल. So this is our normal octopus. This is a stabilizing device which we use for conventional open heart surgery, conventional bypass. Using the same octopus, we have done left internal mammary to LAD grafting through the left thoracotomy incision. In the previous picture, I showed you the octopus which we use routinely for open heart surgeries. But as you can see in this incision, the octopus has covered is occupying the entire space. The पूर्ण space cover करते. It's not of cluttering. तर सिंगल ग्राफ्टला शक्य आहे, पण जर 2 किंवा 3 ग्राफ्ट आपल्याला करायचे असतील, तर मग या ऑक्टोपसने दिसायला प्रॉब्लेम होतो. इन्स्ट्रुमेंट्स पण आत घालता येत नाही. तर जर ग्राफ्ट जास्त असतील, तर we need specific instruments for that. So this next picture, it shows the stabilizing devices passed to the subcutaneous tissue. This is in the ZIFI, this is in the left fixed intercostal space. And with the help of both these devices, we can stabilize the heart. One is used to stabilize the apex so that we can move the heart around in the incision. The other is used to stabilize the actual vascular area where we are going to put the graft. So using this, we can actually vascularize all the 3 territories. And since the stabilizing device is not in the incision, we can use the entire incision for the grafting. This is the post-op result. This is my very first mid-cap, which I did 2.5 years ago. First mid-cap done at Ruby Hall. Minimally invasive CABG. This particular patient had 2 blockages, one in LAD, one in RCA. I gave a lima to LAD and a radial artery to RCA. And the particular gentleman was 45-year-old, very young, chronic smoker. And he had an LV apical clot, ejection fraction 35%. But he's still following up, he's doing very well, and since both were arterial grafts, his EF has gone up to 55%, and he's back to his normal routine. This next patient, he also had 2 grafts. It was LAD and OM, and this is post-operative 5. The initial picture I showed you, it was on table, and this is post-operative 5. The scar has contracted, it has healed well. And over a period of few months, it contracts even further. This is another patient. This gentleman also had 2 grafts, both also done minimally invasive through left thoracotomy, LAD and OM, that is circumflex system. And this is after 2 months. So barely visible scar. And the confidence level of the patient and activity level is very good because healing doesn't require time. They are back to their normal routine within 2 weeks. Like I said, special instruments are required. This is where the cost factor comes in. जे routine instruments आहेत त्याने obviously इतक्या depth मध्ये पोहोचणं difficult असतं. The density is very less. The space available is very less. So these are all long handle instruments which are needed for minimally invasive. Long aortic punches. Needle holders are also long. This is a grasper. Usually जे laparoscopy ला use करतात abdomen साठी same instruments थोडे short length मध्ये ते use करतो आम्ही minimal invasive साठी. The next example, this is mini sternotomy aortic wall replacement. Like I said, aortic wall replacements and mitral wall replacements, both can be done through minimally invasive techniques. This particular patient, he was 32-year-old, a bicuspid aortic wall with severe calcific aortic stenosis and severe breathlessness and chest pain on exertion. So a mini sternotomy or a heavy sternotomy is usually performed in the left, third or fourth intercostal space on the right side. एक मॅनोग्राम आम्ही कम्प्लिटली डिवाइड करतो आणि जे रिमेनिंग स्टर्न आहे ते पार्शियली डिवाइड करतो अँड थ्रू दिस इन्सिजन वॉट एव्हर इज रिक्वायर्ड फॉर AVR दॅट ऑल इज विजिबल. याच्यासाठी फिमोरल कॅन्युलेशन लागत नाही, डिफरंट काही इन्स्ट्रुमेंट्स लागत नाही, स्टेडर पण लागत नाही. नॉर्मल रुटीन इन्स्ट्रुमेंट्समध्ये ह्या अप्रोचने आपण करू शकतो. What we need for aortic wall replacement is only the aorta which should be visible along with the arch vessels and the right atrial appendage part of the right atrium and the pulmonary vein. So everything can be seen through this incision once retracted and pericardium is hitched. So this is an intra-optic of the same patient. Like I said, the aorta is visible. This particular cannula is in the right atrium. The aortic cannula is not in its here somewhere beneath the drape. And from here we can do the AVR. The same surgery which would require a very big incision starting right from the mandible to the down to the ZIFI around 12 to 15 centimeters. It was done with a 3 inches incision, just 6 to 7 centimeters. This is the post-op result. Normal sternotomy would be from here till here. The drains would be somewhere here. But we managed to do this in 2.5 inches incision. And this I am doing routinely now because AVR for this incision is as easy as a routine sternotomy. Now this particular patient, he is doing very well now. He is now almost 3 years post-operative. He is doing trekking, hiking, doing his regular job and everything like a normal patient. For aortic wall replacement, there is another approach also. This is right anterior thoracotomy, done either in the second or the third intercostal space. तर हे आपण कसं डिसाइड करतो की मिनी स्टेनोटॉमी करायचं की राईट सेकंड और थर्ड इंटरकॉस्टल स्पेस करायचं. So we do a cardiac CT for this. Cardiac CT with 3D reconstruction whereby we can see the relationship of the sternum to the aorta. जर aorta patientचा जो आहे it is directed to the more to the right so that the root is directed to the right, then we can use this approach. But जर aorta entirely behind the sternum आहे तर हे approach suitable नाही आहे. तर त्या केसमध्ये मिनी स्टेनोटॉमी will be more better option for the patient. The third one is the mitral valve replacement. Like I said, conventional surgery, a big incision, minimally invasive, we do usually to the right fourth intercostal space. Same approach as ASG. From here, we can see the left atrium, the right atrium, everything very clearly. The cannulation required is partly femoral and partly we can do through the same incision. This particular pic shows the approach. Here, this is the left fourth intercostal space. This cannula is in the SVC, this cannula is in the IVC. Only the venous cannulation part is done through this incision. The arterial cannula was put in the femoral artery and we went on a femoral bicable bypass. And then we could do this patient to the same incision. Rest all things are same, nothing else differs. The only difference is the approach and how we cannulate the patient. Cardioplegia, everything else, how we arrest the heart, how the heart comes by, cross clamping, everything else is the same. This is a picture of femoral cannulation, this femoral artery cannula and femoral venous cannula, where we don't need to open the right atrium. There we can put the cannula in the femoral vein also, and those surgeries can be done. Then the cannula which I showed in the previous picture, this SVC and IVC, these are avoided if you put the femoral vein cannula. But for that, the limiting factor is size of the femoral artery and the femoral vein. So for ह्या पेशंटसाठी ज्याला मी प्लॅन करतोय, cardiac CT preoperatively and arterial and venous Doppler preoperatively is very important. We need to know the sizes preoperatively itself so that we know the sizes of the cannula. Depending on the cannula, whether we can achieve complete bypass, complete arrest of the heart or not. This is the same patient, MVR done to the right fourth intercostal space after 2 weeks of surgery. So this incision is better cosmetically, very less pain, healing time is very less. Since the sternotomy takes at least 2 months to heal. The skin may heal faster, but the bone takes long. It's like a fracture in itself. So this approach is very beneficial for the patients, of course, suitable patients. But like I said, even redo surgeries can be done through this incision. Recently I did 2 redos through same incision. See, when we do a sternotomy and a MVR through here, there are adhesions posterior to the sternum, heart पूर्ण चिकटलेलं असतं. But the pleural space is untouched. The pleural space is virgin. So once we go to the right thoracotomy, actually the adhesions are quite less. So if we can go on femoral cannulation and operate from here, then it's quite possible actually. And the blood loss is also very less. The next important thing is robo-assisted CABGs. Like I said, complete robotic CABGs, complete robotic MVRs, AVRs are developing in India, not in the completely developed stage. Right now, currently, it's assisted. So what does assisted mean? Mainly the internal mammary harvesting, LIMA harvesting, it is done robotically. We put in the scopes very similar to the laparoscopic ports, and from there we harvest the LIMA and RIMA, and once the harvesting is done, we open through a small incision and from there we do complete the grafting. Here we can see the surgeon console, the video trolley and the robotic arms. So it's being routinely performed at Apollo Chennai, Apollo Bangalore and few other setups like Vedanta in Delhi, and surgeons there, we are learning from them. Like there are some people who are already doing it and there are some who are in the developing phase. But this is the future. Like Simon sir said that AI is developing very fast pace. It's up to us whether to develop with it or to develop against it. But it is going to be there. So it's better that we accept it faster and we go in the direction, same direction. So this is how a surgeon operates for robotic cardiac surgery. A surgeon may scrub up, put in the ports and the robotic arms, once they are hitched in onto the patient, they move only when the surgeon moves on the console. There are pointers whereby the surgeon moves the pointers and from there we operate. And we can actually scrub out, sit down peacefully and operate from there. and there is an assistant who is sitting by the side of the patient. There is an assistant port. Whatever changes are needed, the assistant can do on the bedside of the patient. So I have been to Chicago for robotic cardiac surgery fellowship. There I have seen this complete robotic CABGs, completely robotic MBRs and ABRs, and it's quite possible. Different are required, different cannula are required, and the cost is too much actually, because the patients which we get, they may not afford the routine CABG also in the cost which we offer. So this is going time to develop, but it's going to be there. These are the robotic arms hitched to the patient. This is the patient. We can see the video here, and the robotic arms already docked onto the patient. This is the port placement for CABG. This is left intercostal, left fourth intercostal space, left sixth, and this is the left second intercostal space. So we put in the scope from here, the instruments from here, and the lima is somewhere here. So we can operate from inside. We harvest the lima. Similarly, on the right side, we harvest the lima, and then we do the anastomosis through a small incision here. We extend the same incision so that the patient doesn't have extra hole here. So this particular port we extend for the incision for grafting. This is another picture. When we do a CABG, we usually wear loops. Magnification required is because coronary arteries, Indian patients specifically 1.5 millimeter, 1.2 millimeter असे असतात. Very small coronaries. And त्यात पण diabetics असतील, smokers असतील, hypertensives, तर ते अजून chronic occlusion होऊन, calcific होऊन, they are very very small vessels. So we wear loops, we operate using loops. The loops मध्ये जे magnification असतं, that is around 4.5 to 4 times, 4 to 4.5 times. त्यात पण we are very happy की खूप चांगलं दिसतंय. And this particular magnification is around 15 times. This is what we see robotically. This lima, this is huge lima, left internal mammary artery. This is an instrument put in through robotic. This is a grasper. And we can actually, when we are sitting on the console, we can see up to the capillary level itself. So the hemostasis is perfect. The dissection is perfect. We know which plane we are going in. Only the limiting factor is there is no tactile sensation. आपल्याला कळत नाही की आपण किती फोर्स लावतोय, किती ओढतोय, किती डीप जातोय. So there is no tactile sensation. So training is required for that. How much to do, what not to do. आता जर आपण ह्या इन्सिजनला लिमिट करायचं हे बोलतोय की थोरासिक इन्सिजन कमी पाहिजे, स्टर्नल इन्सिजन कमी पाहिजे, तर ऑब्व्हियसली वेनसाठी जे इन्सिजन आहे ते पण छोटा पाहिजे. आपण इथे छोटा करणार आणि लेग मध्ये आपण 20 सेंटीमीटरचं इन्सिजन देणार, तर दॅट डझंट मेक सेन्स. दॅट इज नॉट मिनिमल इन्व्हेसिव्ह. So this endoscopic vein harvesting system, it has also been used for the past 5 to 10 years. Similar scope असतं जे आपण लॅप्रोस्कोपीला यूज करतो, आणि सोबत एक कॉटरी असते, डायथर्मी असते, and we dissect it in the subacute plane. And the incision is limited only to 1 to 2 centimeter. This I have been doing routinely at Ruby Hall. The commonest grafts, even if we are offering patient lima Y, we say कि total arterial is पाहिजे, lima Y पाहिजे, but not every patient is suitable. And still, all over India, across India, most of the surgeons, commonest graft used are lima veins. Even if we are able to offer most of the patients lima Y, but some patients are there. Or the other option is radial artery. So endoscopically, radial artery can also be harvested. So that is also an option for minimal invasive cases. So this is how it looks. This is the conventional incision for vein, and this is for endoscopic vein harvesting. So this small incision, we can direct the scope in both the directions, and around 3 lengths vein, that is around 60 centimeter of vein, we can harvest to this small incision. And similarly for radial artery harvesting also, we can use a similar scope, 1 to 2 centimeter incision, and the healing is very fast. This is very good for diabetic patients. Diabetics मध्ये आपल्याला माहिती आहे की healing slow असते, wound खराब होऊ शकतं, sloughing होऊ शकतं, especially leg veins. तर जे wound असतं तर खूप slow heal होतं diabetics मध्ये, inflammation पण बऱ्यापैकी असतं. So I have been using this for the past 1 year almost, and the results are very good, and the vein quality is also very good. So the advantages of minimal invasive cardiac surgery are smaller incision, smaller scar, reduced risk of infection. Obviously, the handling is less. If the incision is small, the risk of infection is also lesser. Less bleeding, because main bleeding is from the sternotomy. When we do a sternotomy, the bone is exposed. Bone may be osteoporotic, may not be in good condition. We obviously cannot ligate the bone to stop the bleeding. So it has to stop slowly, gradually, and with perfect hemostasis. When we do the wiring, there are chances we may hit the lima or the veins on the sides. So with thoracotomy, everything is avoided. Since the bone is not cut, the bleeding is quite less. And once we achieve perfect hemostasis, perfect suture lines, drains as less as 50 ml. We have seen drains as less as 50 ml. Less pain and trauma. The immediate pain post-operatively for the first 48 hours is tremendous because there is a lot of stretching. We are trying to do a big surgery through a small incision. एक छोटे incision मधून we are manipulating a lot. तर इनिशियल जे 2 दिवस असतात पेशंटला पेन खूप जास्त होतं. शोल्डर पेन, बॅक पेन, thoracic पेन, intercostal जे काही एरियाज असतात ते बर्निंग पेन खूप सिव्हिअर असतं. But for that we give intercostal nerve blocks or like I said thoracic epidural anesthesia is there. So it's important that we plan pre-operatively. Anesthesiaचा involvement खूप जास्त असतो. जे cardiac anesthetists आहेत, they also have to plan. Sometimes we leave the epidural catheter inside and थोडं त्याच्यातून आम्ही analgesia देत असतो. First 2 दिवस झाल्यानंतर इन्फ्लेमेशन बऱ्यापैकी कमी असतं, रेट केज पण बऱ्यापैकी स्टेबल होऊन जाते. मग पेन इज हार्डली एनिथिंग, म्हणजे पॅरासिटामॉल पण लागत नाही ह्या पेशंट्सला ऍक्च्युली. दे आर मोबिलाइज सो फास्ट, वी कॅन ऍक्च्युली डिस्चार्ज ऑन day 4 or day 5. So there is decreased length of stay in the hospital and decreased recovery time for these patients. The disadvantages, as I said, is technically demanding. Initial learning खूप असतं. जर मी रुटीन बायपास 1.5 तासात 2 तासात संपवते 4 ग्राफ्स, तर ह्या सर्जरीला मला 4 ग्राफला 4 hours लागतात. 4.5 hours, 5 hours मे बी. जर बायपासवर जायला लागलं, हार्ट लंग मशीनला कनेक्ट करायला लागलं, ऑन पंप जर केस करायची असेल, फिमोरल कॅन्युलेशन लागतं, कॅन्युलाचे टाईप डिफरंट असतात, कॉस्ट फॅक्टर येते. सो टेक्निकली इट्स व्हेरी डिमांडिंग. म्हणजे त्यासाठी परफेक्ट आपल्याला प्री प्लॅन करायला लागतं सगळं. It requires training at specialized centers. Like I said, I have done fellowship at Chicago, at Apollo Hospital Chennai, Apollo Hospital Bangalore, but still I am learning. असं नाही आहे की केलं आणि होऊन गेलं झालं. म्हणजे इट्स डिफिकल्ट, इट टेक्स टाइम, इट हॅज टू डेव्हलप स्लोली अँड स्टेप बाय स्टेप हे डेव्हलप होतं. It's very expensive. Specific instruments are required. Cannula are different. I showed a slide where the stabilizing devices were there. ते ऑक्टोपस जे होते ते स्किन मधून इंटरकॉस्टल स्पेस मधून टाकतो. एक ऑक्टोपस इज वर्थ अराउंड 4 lakhs, 4.5 lakhs. सो ऑब्व्हियसली ते पॅकेज गोज अप. जे काही आपलं रुटीन बायपासचं पॅकेज असतं त्याच्यापेक्षा जे डिस्पोजेबल्स कन्झ्युमेबल आयटम्स आहे 1.5 to 2 lakhs ने जास्त होतं. सो वी हॅव टू गिव्ह दिस आयडिया टू द पेशंट प्री ऑफ इटसेल्फ की ह्या सगळ्या गोष्टी होणार आहेत. बिकॉज इफ दे वॉन्ट समथिंग गुड ऑब्व्हियसली इट कम्स ॲट अ कॉस्ट. And it's not appropriate for every patient. There are specific contraindications. Suitable patients, like I said, mitral wall, aortic wall replacements, most of the times with good LV function, where the pH is not much, pulmonary artery pressure normal आहे, खूप जास्त chronic नाही आहे, खूप adhesions नाही आहेत, ते patient suitable असतात. सेकंड, ज्यांना काही thoracic issues नाही आहे की adhesions नाही आहे, आधी TB, COX, empyema असल्या काही गोष्टी नाही झालेल्या किंवा COPD. बिकॉज मोस्टली हे जे सर्जरीज आहे ह्याच्यासाठी सिंगल लंग व्हेंटिलेशन लागतं. आयदर राईट लंग डाऊन असतं किंवा लेफ्ट लंग डाऊन असतं. सो COPD वाले पेशंट्स, अस्थमॅटिक पेशंट्स की ज्यांना ऑलरेडी काहीतरी पल्मोनरी रिस्क फॅक्टर्स आहेत, दे आर नॉट सुटेबल फॉर दिस प्रोसिजर. कारण सर्जरी तर होऊन जाईल पण मग पोस्ट ऑफ व्हेंटिलेटर स्टे, पोस्ट ऑफ मोबिलायझेशन, फिजिओथेरपी त्या सगळ्या गोष्टी डिफिकल्ट होतात. These are the contraindications. Morbid obesity. The retractors, they are very small in size. So अगर चेस्ट वॉल खूप जर मोठं आहे, खूप थिक आहे, पेशंट खूप ओबीज आहे, 110 किलो, तर रुटीन मिनिमल इन्व्हेजिव्ह जे आहे की जे थोरॅकोटॉमीने करतो, दॅट इज व्हेरी डिफिकल्ट. बट रोबोटिक अँड एंडोस्कोपिक इज स्टील पॉसिबल बिकॉज द स्कोप कॅन पेनेट्रेट थ्रू दॅट थिक स्किन. आत जात गेल्यावर तर सगळं सेमच असतं. thoracic cavity is going to be the same. What we need to overcome is the thickness of the chest wall. So minimal invasive routine thoracotomy is difficult for morbidly obese patients. And previous lung surgery or infection, like I said, आधी जर tuberculosis, empyema, effusion किंवा past lung surgery ची हिस्ट्री आहे तर मग त्या पेशंट्सला सुटेबल ऑप्शन आहे. कारण लंग ॲडरंट असतात, मग खूप डिसेक्शन करायला लागतं, एअर लिक्स बसतात, नंतर ट्रेनमध्ये बऱ्याचदा एअर येत राहतं, ड्रेन्स लवकर निघत नाही, तर त्या पेशंट्सला हे सुटेबल ऑप्शन नाही आहे. अँड विथ अस्थमा अँड COPD ऑफकोर्स. Severe LV dysfunction, ज्या पेशंटचं इजेक्शन फ्रॅक्शन कमी आहे 25%, 30%, एनलार्ज LV आहे, सिव्हिअर डायस्टोलिक डिस्फंक्शन आहे, हायपरटेन्सिव्ह पेशंट, सिव्हिअर LVH आहे किंवा LV अपायकल क्लॉट आहे, MR आहे, असे पेशंट्स हे प्रोसिजर टॉलरेट नाही करत. शक्यतो ह्या पेशंट्सला बायपासवर टाकायची गरज पडू शकते, ऑन पंप करायची गरज पडू शकते. अँड द हार्ट इटसेल्फ इज एनलार्ज थ्रू दॅट स्मॉल इन्सिजन. ऑल वी कॅन सी इज ओनली द अपर पोर्शन ऑफ द अँटेरियर वॉल ऑफ द LV, बाकी काही दिसत नाही. So patients with severe LV dysfunction are not suitable for this procedure. They can be post-op stunning also. तर त्या छोट्या incision मधून आपण हे करायला ट्राय केलं. There is lot of stunning post-operative support requirement पण जास्त असते. So they are not suitable patients. ज्यांना conventional option दिलेलंच better आहे. And other wall or associated problems. If we are going to do 2 or 3 concomitant procedures like CABG with wall replacement, CABG with MVR or double walls. those patients are not suitable because approaches are totally different. One incision may be on the left side, the other may be on the right side, the next may be in the third or fourth intercostal space. So that is not suitable. For them, midline sternotomy is the best. So there are 4 levels of technological or advancements in cardiac surgery. Mini incision or direct vision. The photographs which I showed you, they were all direct vision. Where we do a thoracotomy, heart is directly visible in the incision. Next would be micro incision or video assisted. ह्या केसेसमध्ये आम्ही थोरॅकोटॉमी करतो छोटीशी आणि दुसऱ्या छोट्या इन्सिजन मधून वी पुट इन द एंडोस्कोप ऑल्सो स्कोप पण टाकतो तर स्कोप मधून पण दिसतं आणि थोरॅकोटॉमी मधून पण दिसतं सो दॅट इज असिस्टेड वी टेकन इन्सिजन ॲज वेल एज व्हिडिओ असिस्टेड तर हे बाकी ओटी मध्ये जेवढे पण लोक असतात त्यांच्यासाठी खूप सोपं होतं की सर्जन त्या इन्सिजन मधून काय करतोय ते त्या स्कोप मधून त्यांना स्क्रीनवर एकदम व्यवस्थित दिसतं. The third would be micro or port incision or video directed. Here we don't take a thoracotomy incision. पूर्ण व्हिडिओस्कोपिकलीच असतं जसं आपण लॅप्रोस्कोपिकली कोलेसेक्टमी करतो सिमिलर वे इट्स थोरॅकोस्कोपिक सर्जरी पूर्ण पोर्ट्समधूनच होतं. एक असिस्टंट पोर्ट असतं 2 सेंटीमीटरचं त्याच्यातून फक्त वॉल आतमध्ये पास करायचं सुचर्स बाहेर काढायचं आत टाकायचं तेवढं काम फक्त असिस्टंट करतो. And fourth, like I said, is robotic, whereby the surgeon sits on the console and does it, and assistant assists on the bedside. So most of the surgeons are in this space, mini incision in India. There are quite few actually. Maybe जे टोटल सर्जन्स आहेत त्यातले हार्डली 10% असतील की जे ह्या स्टेजला आहे. हे स्टेज खूप लांब आहे. तर ऍक्च्युली जर पेशंट्सला एक्सेप्टन्स आलं डॉक्टर्सला एक्सेप्टन्स आलं तर मग कुठे हे याच्या पुढे डेव्हलप होऊ शकतं. इथे रेजिस्टन्स ऍक्च्युली बऱ्यापैकी आम्हाला डॉक्टर्स कडून पण येतं की मिनी इन्सिजन मधून कम्प्लीट सीबीजी होऊच शकत नाही पण इट इज नॉट दॅट. अगर सुटेबल पेशंट आहे तर ते पण आपण मिनी थोरॅकोटॉमीने करू शकतो. Like I said, apart from minimal invasive complex procedures, redo procedures, they have also developed. I have included just 2 examples whereby किती आपण काय लेवल पर्यंत ऑपरेट करू शकतो, कसे ट्रीटमेंट्स करू शकतो. Ventricular septal rupture and LV aneurysm. Ventricular septal rupture and LV aneurysm वाले पेशंट्स जे असतात ते शक्यतो खूप बॅड कंडिशन मध्येच येतात हॉस्पिटलला. VSR इज अन अक्यूट एमर्जन्सी. युजली ते कार्डिओजेनिक शॉक मध्ये असतात हाय सपोर्ट्स मध्ये असतात इंट्रायोटिक बलून ऑलरेडी टाकलेलं असतं मोस्ट ऑफ द टाइम्स. या पेशंट्स मध्ये मॉर्टॅलिटी इज अराउंड 70 to 80%. व्हेरी फ्यू पेशंट्स ऍक्च्युली निघून बट इफ प्लॅन प्रॉपरली पेशंट आल्याला पण IBP टाकलं व्हेंटिलेट केलं पेशंटला जे काही त्याचे सपोर्ट्स आहे ते ऑप्टिमाइज केले आणि मग ओटीला घेतलं तर रिझल्ट बऱ्यापैकी बेटर असतं. अँड सर्जिकली वी हॅव टू बी परफेक्ट अबाउट वॉट एव्हर पॅच वी पुट इन. LV aneurysm जर आहे तर त्याला जे काही आपण रिपेअर करतोय त्याचं हिमोस्टॅसिस परफेक्ट पाहिजे. वी नो की इट्स अ व्हेरी हाय रिस्क केस तर तिथे मग ब्लिडिंग होऊन हे होऊन ह्या सगळ्या गोष्टी वी हॅव टू अवॉइड. वी डोंट हॅव टू गिव्ह एनी एक्स्ट्रा इन्सल्ट टू द पेशंट. पेशंट ऑलरेडी एक मॉर्बिड स्टेटमध्ये आहे तर त्याच्यातून आपल्याला त्याला बाहेर काढायचं असतं. So this particular patient, he is a 52-year-old gentleman. He came from Nigeria to India to visit his mother. And he developed breathlessness, only breathlessness, no other symptom. He just went to his physician and he could oscillate a murmur. तर त्याला मग कार्डिओलॉजिस्टकडे पाठवलं तर he had a ventricular septal rupture. This is the ventricular septal rupture. हे मिक्सचर जे आहे ते interventricular septum मध्ये. This I have opened through the LV apex. This is the LV apical aneurysm entirely thinned out. जो पेशंट नायजेरियाला वर्किंग आहे जॉब करतोय एसिम्प्टोमॅटिक आहे टोटली. ही केम टू इंडिया जस्ट टू विजिट हिज मदर अँड ही लँडेड अप विथ दिस अँड वी हॅड टू ऑपरेट बिकॉज ही वॉज 51 year old. IBP टाकलेलं होतं सपोर्ट्स वर व्हेरी हाय बट सिन्स बिंग यंग पेशंट्स दे टॉलरेटेड बेटर. म्हणजे त्याला सोडून देणं दिस इज नॉट अन ऑप्शन जस्ट बिकॉज मॉर्टॅलिटी इज हाय. सो या पेशंटला देर आर 2 things. दिस वन इज द VSR repair. This is a double sandwich patch. Bovine pericardium and PTFE फेल्डचं पॅच असतं. तर त्याचं सँडविच पॅच इथे आपण टाकलेलं आहे. सुचर इंटरप्टेड सुचर्स आहेत बिग प्लेजिटेड सुचर्स आहेत कारण हे व्हेंट्रिक्युलर सेप्टल रप्चरमध्ये जे टिश्यू असतं दॅट इज व्हेरी फ्रायबल. ते सुचर्स होल्डच करत नाही. सो इफ नॉट डन प्रॉपरली ते टेअर होत जातं वाढत जातं. सो रिपेअर विच इज डन फॉर द फर्स्ट टाइम इज द बेस्ट रिपेअर अँड दॅट हॅज टू बी परफेक्ट. जर ते बरोबर असेल तर मग लीक वगैरे वगैरे बाकी गोष्टी होत नाही. So that is the septal patch. हे LV apical aneurysm आपण पूर्ण उघडलेलं आहे and this is post repair of the aneurysm. ते जे काही aneurysmal tissue होतं ते एक्ससाइज केलंय. इथे पण डबल पॅच टाकलेला आहे and the repair hold well. It held well. पोस्ट ऑप आम्ही त्याला IBP 5 days ठेवलं. ग्रॅज्युअली IBP विन ऑफ केलं. इंट्रायोटिक बलून विच इज अ सपोर्टिव्ह डिव्हाइस. वी insert it just for 4 to 5 days till the patient recovers, till the cardiogenic shock recovers. तर ते बलून आम्ही 4 days नंतर काढलं, सपोर्ट्स ग्रॅज्युअली विन ऑफ केले. पेशंट गॉट डिस्चार्ज ऑन day 10. Now it's around 6 months post-operatively, he is going back to Nigeria and is doing very well. EF is still down to 35% because जे काही aneurysmal portion आहे that was non-viable. त्याला काही करता नाही आलं. LLT territory was entirely non-viable. But RCA and OM was quite viable. तर RCA and OM graft करून हे रिपेअर करून LADचं जे काही septal part, aneurysmal part होता that we had excised. So his LV cavity, the LV diameter also came down to less and is doing very well with nominal medications actually. This next case is a valve rupture. This case we did recently at Ruby Hall. This gentleman, he came to our casualty in a complete shock state, cardiogenic shock. No urine output. We had to start noradrenaline very high dose. And he was 71-year-old, but physically very active and a very fit gentleman. And the diagnosis immediate was LV rupture. It was in the basal area, the circumflex territory, जो posteriorly असते, L appendage जवळ असतं. And it was a contained rupture. म्हणजे खूप मोठा तिथे tamponade होता, खूप मोठा clot होता, around 10 by 8 centimeters clot होता, and त्याच्यामुळे it was contained. And because of cardiogenic shock, his creatinine, he was in renal failure also. Creatinine was up to 3.4, 3.5. But he was not ventilated. He was breathing calmly. His saturation was normal. He was conscious, alert. He was knowing everything. He was understanding everything. This particular variety, cardiac rupture, it has a mortality of around 98%. Patient hospital आपण पोहोचत नाही. But this particular patient, he reached hospital. So we thought, why not give him a chance? जर तो hospital पर्यंत आला, maybe he'll sustain the surgery also. So we opened him up, we didn't directly open him up because the tamponade मुळेच ते actually bleeding contained होतं. So we were worried की direct open केलं तर ते bleed out होऊन जाईल patient. So we first went on a femoral bypass, femoral artery, femoral vein bypass वर गेलो. त्याच्यानंतर स्टेनोटॉमी केली and by the time everything was in control. And after that हे क्लॉट रिमूव्ह करून सगळं करून इथे मग पॅच लावून त्याला रिपेअर केलं. Similar patch, double sandwich patch like I showed in the previous picture. And this particular patient also went home on day 8. Supports gradually कमी झाले. Balloon त्याला लागलंच नाही because rest of the LV function was good. We did bypass with this rupture repair. And the patient with good creat also came down, supports came down. He went home walking actually. And this particular case was published in the newspaper also. The next important thing is, like I said, from being a surgeon, I will do all the things. But जर OT मध्ये support system तसं नाहीये, cardiac anesthetist तसं नाहीये, perfusionist तसं नाही, तर results duplicate होत नाही. So it's a team effort. Everybody has to do their best. तर importance of intraoperative TE. TE is transesophageal echo, which is most of the times done by cardiac anesthetist. Ruby Hall मध्ये we insist that every patient we have a TE inside. We have 2 different TE groups. Both theaters have continuously going on. ऑफ-पम्प केसेससाठी इम्पॉर्टंट आहे बिकॉज टीईवरच आपल्याला कळतं की हार्ट फुल आहे, एमटी आहे. विज्युअली आपल्याला एक जजमेंट येतं, बट परफेक्ट नॉलेज वी गेट थ्रू टीई. सो द कार्डियक एनेस्थेटिस्ट कॅन गाईड द ड्रग्स, द आयव्ही फ्लुइड्स, द ब्लड अकॉर्डिंगली. पोस्ट सीपीबी रिकव्हरी आपण जेव्हा ऑन पंप केसेस करतो, वॉल केसेस बाय डिफॉल्ट आर ऑन पंप केसेस वेअर बाय हार्टलाईन मशीनला आपण कनेक्ट करतो आणि हार्ट अरेस्ट करून करतो. तर पोस्ट ऑफ रिकव्हरीमध्ये आरव्ही डिस्फंक्शन आहे का, एलव्ही डिस्फंक्शन आहे का, वॉल लिकेज कसं आहे, वॉलचं स्टेटस कसं आहे, पॅराव्हॉल्व्युलर लीक, इंट्राव्हॉल्व्युलर लीक, ह्या सगळ्या गोष्टी आपल्याला ऑन टेबलच कळतात इव्हन बिफोर क्लोजिंग द पेशंट, सो दॅट वी आर 100% शुअर की वी हॅव डन अ गुड जॉब. So that is why TE is very important. De-airing, whenever you open the heart chambers, of course some air is there, is bound to be there. That the air completely गेली आहे की नाही ते 100% confirmation TE वर येतं. Otherwise there are micro bubbles which are obviously there. जर TE नसेल तर आपल्याला माहिती होत नाही. So we vent the heart till the time all the bubbles are gone and then we close the vent. And on-table surprises. There is one very good example of on-table surprises. This particular patient, she is a 61-year-old female. She had severe MS for the past 1 year. She knew she needed the surgery, and there was a big LA clot, and the clot was occupying the entire LA on the preoperative 2D echo, and she had a mild TR. No other finding on the preoperative 2D echo. जे आम्ही 1 दिवस आधी करतो. As a protocol, आम्ही 2D echo 1 दिवस आधी करतो सर्जरीला घ्यायच्या आधी. These were the only findings. इंट्राऑपरेटिव्ह टीई प्रोब टाकल्यानंतर बिफोर टेकिंग द इन्सिजन आम्ही टीईवर सगळं कन्फर्म करतो की जे काही फाइंडिंग 1 दिवस आधी होती ते सेम आहे का. In this particular view, you can see this is the left atrium, this is the right atrium. Here is the mitral valve and this is the aortic valve. This is a LA clot. The entire LA is not seen, but पूर्ण LA भरलेलं होतं. Only this is the part की जिथे थोडंफार blood होतं. Otherwise, entire LA was filled with blood, and this is we call LSO. This particular RA, previous echo they said कि RA मध्ये काहीच नव्हतं. Mild TR only, no other finding. Here we can see something jumping here. This is an RA clot, and this was not there previous day. This we noticed on table just before opening the patient on TE. So this particular was RA clot. The patient had a pulmonary DVT had embolized overnight just before taking for the OD. She was recommended not moving around much because of dyspnea and exertion. So typical long clot which was moving about in the RA. She was very lucky that it didn't embolize to the pulmonary artery. Otherwise, she would have had a collapse right before surgery. So operated on this patient, this is the RA clot, typical DVT embolized to RA, a long clot, DVT from the femoral vein. This is the mitral wall, severely calcific, fish mouth appearance, and this entire was the LA clot. The entire LA, including the pulmonary veins, there was no remaining area where the blood could flow. This was sitting on the wall, occupying all the veins. We removed the entire thing, we replaced it with a tissue wall. The patient was 62-year-old and she did very well post-op. So if the TE was not there, I would not have opened the RA. I would have done only the MBR. I would have done only the LA clot. And this we could do because the TE was there. So what has changed? The surgical techniques, better anesthesia protocols, improvement in perfusion technology, whatever on-pump cases is there. Perfusionist, it occupies an important part of the team. A good perfusionist is paramount for a good result post-surgery. Post-op care, physiotherapy, rehabilitation, and ERAS protocols. Like I said, it's all teamwork. And this is me, my assistant scrub nurses. We cannot see the people in the background. The cardiac anesthetist is not seen here. He is behind the curtain. And the perfusionist is not seen here. But they are the two most important members of the team who ensure that the results are good. So the most important and the key factor is patient safety. Be it minimal invasive, be it conventional, open heart करू, कसं पण करू, कुठली technique में करू. But patient safety is the most important thing. The bottom line is that the patient should go home walking. ज्या condition मध्ये आला होता त्याच्यापेक्षा better condition मध्ये घरी गेलं पाहिजे. If we can achieve that with any kind of technique, that is what matters at the end of the day. Thank you so much.
Thank you so much, Dr. Smriti ma'am, for delivering a very informative lecture on advanced cardiac surgery with aesthetic healing. Now I would request General Manager of Ruby Hall Clinic, Mr. Julius De Cruz, to deliver his talk and brief us with his video.